Wonderful. Well, thank you all so much for joining. It is great to see all of you who have decided to spend time with us this morning, this afternoon, this evening. Welcome to our third webinar hosted by the Department of Community Health and Social Medicine here at the University of Global Health Equity. My name is Zahira, and I'm an assistant professor here at the Godley St. Gord Chair of Community Health and Social Medicine. We are so delighted for you to be with us and grateful for your time and your interest in this webinar series and in today's session specifically, entitled Community Health Interventions, Perspectives from Palestine. This session is a part of a year-long skill building series focused on improving our approaches to advancing community health. For many of you, this may be your second or third session, and so we're grateful for your engagement in this way. Our goal in each conversation is to take away new tools or approaches that can be applied in our own community-based work. Our past discussions have been about research, social justice, participation, and advocacy in South Africa, Canada, and Uganda. Today's episode will include a deep dive into one community health worker program in the West Bank in the occupied Palestinian territories. As you know, community health work programs exist all over the globe, in India, Ethiopia, Pakistan, Rwanda, but the context in which today's discussion takes place is quite different. You will hear from our two speakers about their program, of course, but in the context of what the UN calls rising settler violence and illegal military occupation by the State of Israel. And notably, what a recent 224-page Human Rights Watch report calls apartheid and persecution. Connections must be made between health and equity and social justice and human rights, racism and health outcomes. And we will consider all of these things and how health programs function under protracted conflict and crisis, and how communities do what they always do: rise up every day in the face of oppression and work on one of our core functions as a human family: healing. We cannot shy away from the current situation in Palestine and Israel, the forced evictions of Palestinians in Sheikh Jarrah, the Israeli security forces' attack on Al-Aqsa Mosque, the rockets from Hamas, Israel's indiscriminate bombing of residents as well as journalists and humanitarians in Gaza, and the ongoing, decades-long occupation of Palestinian land. Today is a conversation about health, yes, but health at the intersection of state violence, protracted occupation, and forced displacement. So I thank you for being with us today, and I'm really honored to be joined by two guests to help us navigate this landscape and to share their example of community organizing in community health. So let's meet our guests. Please join me first in welcoming Sara Alaza. Sara is a Palestinian refugee who was born and raised in Al-Azhar refugee camp in Bethlehem. She is currently studying Arabic language education at Bethlehem University and teaches a literacy course for elder women in Aida and Al-Azhar refugee camps in the occupied territories. Sara works for Health for Palestine, a community organizing initiative in Palestinian refugee camps that seeks to maximize wellness and address health barriers. Sara works as a CHW with Health for Palestine in the Laji Center's health unit. Please join me in welcoming Sara to today's conversation. Our second guest is Dr. Bram Wispelwey. Bram is co-founder and chief strategist of Health for Palestine. He's an associate physician in the Division of Global Health Equity at Brigham and Women's Hospital and an instructor at Harvard Medical School. Bram's research, implementation, and writing focuses on anti-racist strategies to addressing inequities, community health worker impact, and settler colonial determinants of health. Before the start of his medical career, Bram pursued LGBTQ rights activism, which informs his approach today. Bram is also a senior fellow at the Atlantic Fellows for Health Equity and leads Partners in Health U.S. technical support for the COVID-19 response. I ask you to join me in welcoming Bram to this discussion as well. Bram, Sara, welcome. Murakaza Neza, Marhaban. Thank you so much for joining us. Our discussion will be divided into 3 sections. So I hope this helps all of us kind of navigate where we are as an audience. In section 1, we'll focus on the organization, Health for Palestine, and the larger context in which this work is happening. In section 2, we'll discuss the Community Health Worker Program, its novelty, how it functions, and its impact. And in section 3, we'll close out with a focus on the challenges to implementation and the connections to the larger questions of social justice. As always, in all of these environments, we have a few final housekeeping items. We know that in this virtual world, we don't feel as connected as we can. I'm going to ask you to send questions along all throughout the session as they arise in your mind. Do not wait till the end, keep them coming. And note that after this webinar, you will receive the recording, you'll receive valuable resources, readings, things that can help you move forward in what's being shared today. You'll also receive the answers to any unanswered questions. Lastly, as I hope you have already noted, this conversation is happening both in Arabic and in English. So please note the circular planet-like object at the bottom of your Zoom screen and choose a language that you'd like to be listening to in the rest of the conversation. I'll give you a moment for that. All right. So thank you again for joining us, and let us begin. I'd love, Sada, to begin with you. First of all, thank you so much for joining us today, from logging in from the West Bank. We appreciate your time and your energy and your willingness to engage in this way. And my question for you is if you can help us understand the context in which your work is happening. I imagine our audience is quite diverse in their level of knowledge about Palestinian refugee camps in the West Bank. So can you describe for us the communities where you work and how the people you work with came to be refugees?
Thank you, Zahira. Thank you. Hi, all. I hope you are all well. I live in a land that was created to peace, but I have never seen pieces. This is what is happening in my beloved country, Palestine. I want to talk in Arabic now. If not have problem with all the members in this meeting.
Generally speaking, the life of the Palestinians is very difficult. Most of the people live a simple life, which comes as a reason of the surrounding conditions Palestinians face. And the main reason for this was in the past and in the present is the occupation. In general, the patients we visit or the beneficiaries from community health workers in Palestine in general and in Aida and Al-Azza camps in specific are simple people. They need our help because of the occupation. The level of knowledge people have in camps has its distinguishing quality. The Palestinian community has a high level education among its members in all fields and majors, whether in the medical field or social fields, pedagogy as well, and technology. Many people studied and still studying abroad outside Palestine through scholarships. One important information here is that Palestinian women are well educated and have high level of education. This came as a reason of the occupation and before occupation as well. That's why the level of education among Palestinians is high and have a diversity types of knowledge. For the levels of education in camps are considered to be high. They are knowledgeable and well educated. For the medical field and health-wise, they have the basic knowledge. We know that because of our work, as we contact a lot of people, we can say that most of the people have the general basic information. For the specialized information in medicine, only people specialized in the medical field has this knowledge. We worked a lot and put much effort in raising awareness in the medical and the health field, as through health sector we can overcome many challenges in our lives.
Much, Sada, much appreciated for giving us a little bit of context about where you're working and the communities you're working with. I'd like to now invite Braham to expand on this a bit and connect for us what is happening now in Sheikh Jarrah and Gaza and elsewhere with the history of the communities you and Sarah are serving. So how is their refugee story related to the current affairs that we're all observing?
Thanks so much, Sahara. I think this is, this is really important in understanding why Sarah is a refugee and why she grew up in a Al-Azhar camp is sort of key to understanding even what's going on today, right? That's probably in the news and sort of almost anywhere in the world right now in terms of what's going on in Palestine and Israel. And so, the story really starts, it's one that's recognizable to, I think, many of the listeners today, right? It's really one of a form of colonialism called settler colonialism. Colonialism is about domination and exploitation of indigenous populations by, colonial powers, usually European powers, right? And they often exploit, indigenous native peoples to extract resources and to extract their labor, right? But in the case of settler colonialism, which is the kind that we have in the United States of America, it's not so much the goal to exploit the workers as it is to eliminate the indigenous people, in the words of Patrick Wolf, one of the scholars of settler colonialism. And so really what you have in Palestine is really a process that began in the late 19th century, and that was most dramatic in 1947, 1948, when the vast majority of Palestinian people became refugees, over 750,000, more than 85% of the population, in what's known as the Nakba, or the catastrophe in Arabic. And in fact, even though the Nakba refers to that 1948 event, as Sara and the Palestinians we work with can tell you, this is really an ongoing, continuous process, right? This is an enduring structure, not a single event. And so that is the event that led to Sara's family being displaced from their homes in Beit Jabrin in what's now Israel, and a same process that's continuing today in Sheikh Jarrah, the forced eviction, right, or displacement, or when you have displacement that's from one racial or ethnic group that's stronger and in power over another, it's called ethnic cleansing. So what we've been having in East Jerusalem over the last few weeks is a process of ethnic cleansing that led to the current escalation of violence, with Israel now dropping bombs extensively on the Gaza Strip, killing 59 children in just the last few days alone, and some of the top medical personnel working in Gaza Strip. And so again, that whole process, the reason, Sara is a refugee, the whole community working with are refugees, it's the same process that's continuing to displace people at this moment.
Thank you very much, Bram, for a bit of the history and context to help us make some of these connections. I'd like to stay with you for a moment and step into the discussion on the health of Palestinians, right? So some of that is as a result of things that we teach and talk about at UGHE around social and economic and political and commercial and colonial and all sorts of other sorts of impacts on society. So can you help us understand the day-to-day health concerns of Palestinians living in the refugee camps where you all are doing this work?
Absolutely, and that was really the first part of our process. The refugees we work with in Aida and Al-Azhar camps, they didn't have a dedicated United Nations clinic within their camps. And so we're having tremendous access difficulties. So we really conducted initially some focus groups to better understand exactly this question, what are the day-to-day concerns, what's the process? And what we learned is actually that these Palestinian refugees understood very well the structural determinants of health and the social determinants of health that were keeping them from being able to be healthy. So they linked back their health problems, which are extensive, ranging from chronic diseases like heart disease, diabetes, to lung diseases that they're certainly in their minds are related to the fact that they're the most tear-gassed population in the entire world, according to a study from a Berkeley law school group. But they were able to link all these back to their displacement and their ongoing occupation. They live under a military occupation. They suffer night raids, 3, 4 in the morning from the Israeli occupation forces on sometimes a daily basis, certainly a weekly basis. They're living in constant fear of arrests of their children, even as young as 10 years old, being picked out in the middle of the night. And so it's a context in which it's very difficult to be healthy. Overcrowded, triple the population density of Manhattan in these refugee camps, and very difficult even to do basic things, get your medications right. There's frequent medication stockouts, very difficult to get to the clinic, to exercise, to eat healthy. All of these things are driven by the political scenario, as you said, the political and the structural. And actually what we found out in the focus groups is that the people we work with, the patients, the community, they understand these things very well.
Great. Thank you so much, Ram, for making those connections for us as well. And Sada, I'd like to return to you. I understand that you were born and raised in Al-Azhar refugee camp, as both you described and Ram described. And I'm wondering what you want to share about that experience and how did it influence your decision to become a community health worker?
The first reason is that I myself is a refugee. I lived in Al-Azhar camp for 20 years, and after that I got married and moved to Aida camp for 2 years now. So I have experienced all of this. Another reason for me to be a community health worker that my mother has high blood pressure and diabetes, and the Anurwa clinic is very far from the housing units in the camp, which makes it very hard for the patients if they needed to do a daily test, and it will cost them a lot of money. Another reason is the availability of medicine at the Anurwa clinic. We all know that the UNRWA is responsible for the health services for the Palestinian refugees at camps. Most of the time, the needed medications are not available at the clinic. People go a long way to the clinic and they don't find the medication needed. And if the medication is available, it is not with the same quality of the medicine that you buy from pharmacies. This what urged me to be a worker in this field. For sure, we do not replace UNRWA or any other specialized authority to provide health services. We help these parties in delivering services and provide the support for the people who live in camps to reach a level of equality between them and other people outside camps, because receiving healthcare is an essential right. As we look at it, healthcare is a right that should be given to everyone all around the world. We do not have this right. It is not given to us, as we don't have a clinic in both camps. If a patient needed an emergency visit to check their blood pressure or sugar levels, we provide this service to them, as it is our field of work, and there is no provider for this service. If the patient goes to a specialist, he or she has to pay a lot of money for this service, and the economic situation at the camp is very difficult. Also, the idea occurred because I wanted to volunteer in something that is not related to my career or to the field of my study, as I am a student. And the community health worker was a new pioneer idea in Palestine. You can say that the main reason is I lived the experience and I wanted to provide support for the people who are living it and provide humanitarian aid for these people, as they are marginalized and overlooked by the community.
Thank you so much, Sada. I appreciate you describing a little bit as to what motivated you to take on this kind of role, both personally and professionally. So thank you for that. Bram, I'd like to ask you to bring us into the weeds a little bit, to tell us about the Community Health Worker Program in the West Bank. How does it work? How many are there? What do they do?
Yeah, great. There's 10 community health workers. Sarah's one of 10 now working in Aida and Al-Azhar camps, and we're actually just hired 4 more in Balata refugee camp, the largest refugee camp in the West Bank in Nablus, and we're hoping to start soon in the Gaza Strip. So this is the group. They're all refugees, all young refugees, super motivated, very intelligent, educated folks. Had a great pleasure with our, doing the trainings with them originally, going back even now 3 years ago, and they were always looking for more information and sort of just, as Sarah mentioned, right, a very educated group, very educated population, and so they've picked up these things very quickly. But what we do is really accompaniment, right? It's social accompaniment. It'll be familiar to people who are used to the model from Partners in Health, and it's really a model of refugees helping refugees across generations with their health needs and health barriers. As Sarah talked about a little bit, you have these folks, these young people are predominantly going to they're all, what they're doing is home visits, right? So they're going into people's homes, helping them organize their medications, make sure they understand what they're taking, why, helping them, know when to go to their visits, get their blood tests, encouraging them, to do the kinds of things they need to do to be healthy, and figuring out with them together what it's going to take, given all the structural barriers that we've talked about. And so, this process is one of, they usually go out in the morning. They visit all their patients, they come back, they enter all their data into a system that we've built called Kobo, and that's really actually a big part of it too, is that the community really wants ownership over their own data. They want to understand what their health problems are. And so data sovereignty has been a big part of the impetus too for this project and for the work.
Excellent, thank you so much. And so important to think about data sovereignty and how if you control your own information and your own data, that you're able to also come up with your own solutions at a really grassroots level. So thank you for sharing that. Sada, we're going to come back to you because we're really honored to be able to engage with you and thinking about what community health workers do in many countries across the globe. And so it's a real pleasure to hear more about your story. And I'm wondering that, you're working in these 2 refugee camps in the occupied territories. Can you tell us a little bit more about your specific role? And then maybe give us an example of day to day, the kinds of things you're doing.
Of course. ممكن أنا راح أحكي عني وعن
I will talk on my behalf and on the behalf of my group. As Brian mentioned, we are 9 people. We work at 2 camps. The total number of population in the 2 camps is around 7,500 person. We held many medical free days at the camps, and we noticed that the 2 prevalent diseases are high blood pressure and diabetes. As I mentioned earlier, the UNRWA clinic is very far from the camp, and the economic situation is very difficult. Aida camp in specific faces the most of the violations from the occupation forces in the West Bank, and especially attacks with tear gas bombs. Even there was a female martyr in Aida camp who died as a reason of being exposed to a huge amount of tear gas. As community health workers, we come from different major backgrounds such as nursing, pedagogy, medical laboratory, and midwifery. We work in groups. Each group works with 30 patients, males and females patients, with an age group between 40 years and 85 years old. These patients need continuous medical care, a visit or 2 on a weekly basis. For example, if there was a patient who has a very high blood pressure and has many other problems, we provide intensive visits for him, like 2 or 3 visits per week till his situation is stable. This was before COVID crisis. For sure, the crisis added an extra load for us. We also have regular visits for patients. We visit the patient and check on him or her. We provide them with healthcare, psychological support, as well as we regulate their medications. The main objective for this is to change the lifestyle of the people in the camp and support them to follow a healthy lifestyle. Also, we work on other aspects of life, which are health, social, and cultural aspects. How do we do that? We conduct annual summer camps for patients. It was a new idea to hold summer camps for elderly people with health activities. Also, we hold healthy group breakfasts every now and then. Our center supports this marginalized group. Also, we have a general practitioner who accompany us during emergency visits. Also, he goes on a monthly visits for patients, in which he checks on the situation of the patient, if he or she needs new medication or if they need to be admitted to the hospital. Also, we have nurses with us in the group. If anyone in the camp reached us for help and support, whether they are in the project or not, we provide support and aid to them. If someone needs to take an injection or to check their blood pressure or sugar level, or to read and explain a report, we provide all these services to them. An important point I need to mention here is most of the people have high blood pressure or diabetes because of the actions of the occupation and the violations it commits against people in camps. Many of the visits we go on are to people whom their son was arrested the day before, or they have a martyr in the family, or someone died in the family. These are the reasons for most of our urgent visits. We go there and provide aid and health support to them, as well as psychological support. In the coming days, God willing, we will have guidelines for psychological support, which will be a clear standard curriculum for community health workers who will be working in camps.
Thank you, Sara. That is very thorough. So I appreciate understanding more about the day-to-day work you're doing, but also the intersections of chronic disease as well as mental health. And so that was leading into my next question, which is really that we understand that that's where you're focusing, like diabetes, hypertension, depression, anxiety. And so Ram, I'm wondering if you can tell us a little bit more or build on where Sara has begun on what's happening in these two camps and why you're focusing on these diagnoses specifically.
Yeah, and a big part of it is the epidemiology. You know, these are the big drivers of morbidity and mortality. You know, the top cause of death in the occupied West Bank are, you know, cardiovascular disease, cerebrovascular disease, and complications related to diabetes. So all things driven. And it also happens that, again, the community really recognized this. You know, it was sort of when we did focus groups, like, yeah, every family has at least one person with diabetes. And I think more and more we understand, right, that these diseases are, you know, they're intimately linked. Things like hypertension, diabetes, intimately linked to depression, anxiety, which in some ways are misnomers, because depression and anxiety, as they manifest in camps like Aida and Al-Azhar, are really markers of social suffering due to an intolerable political context and situation that, you know, people really shouldn't have to live under. And so when you have extreme stresses from the kind of things that we mentioned, you know, night raids in the middle of the night, tear gas, extensive, you know, there's 6 guard towers in a wall twice as high as the Berlin Wall, over 30 video cameras surrounding Aida camp, for example. So living under these conditions really drive, we know now through things like allostatic load and understanding, they drive diseases like high blood pressure and like diabetes, right? And they make them harder to control. On top of that, you have a specific, really a captive economy in the West Bank, and where all imports and exports go through Israel. And you've had a significant changing of the foods that are available and how expensive or cheap they are. That's sort of led to rapid shifts in diet, really, in just the last couple of decades. For example, another way that occupation leads to ill health for Palestinians. And so, you know, certainly the stresses and anxieties that Sarah was mentioning that they do work around feed into the disease, you know, these chronic diseases, and then vice versa. It's almost a vicious cycle, and that's a cycle we're trying to do everything we can to mitigate on the ground, while also doing advocacy at a higher level to try to, you know, change these conditions, obviously, that people are living in. And that really requires liberation, right? Liberation for Palestinians that are living under occupation, who were ethnically cleansed from their original villages. So that's, you know, that's the reason for those focuses. And, you know, and I think it's tying into a literature that fits beyond Palestine, right? Like we know in all areas of settler colonialism, whether it's the United States, Australia, Canada, indigenous communities and other oppressed communities, like Black Americans, for example, in the US, have diabetes rates that are 2, 3, sometimes 4 times as high as the settler colonist white populations, populations like myself, have in those countries, right? And so this fits the exact same pattern, right? Where you have very high rates of diseases like diabetes compared to the settler colonist population. So this is really, it's something widespread.
Great, thank you for that. And just for, I think, making all the different connections between conflict and violence and occupation with our physical and our mental well-being, right? That those things are tied together. So, we are coming to the end of our second portion of this conversation. And so I'd like to come back to Sara. The other key piece of this community health worker program seems to be the concept of accompaniment. And I know that is for the PIH folks who are online quite familiar. And so Sara, I'm hoping that you can tell us, what does accompaniment look like in real life in your work, and why you think it's an important component of community health work? So what is it? What does it look like in your work, and why is it important?
أنا رح أجاوب لشقين للسؤال. إن كان المرافقة للمريض.
I will answer the 2 points in the question. For accompanying the patient, it is very, very important, but I do not accompany them 24 hours. A patient would forget to take the medication, and then suddenly he would remember that the community health worker told me to take the medication on time, or to quit smoking, or if he missed a workout on a certain day, he'd remember that, yeah, Sarah told me to that I have to work out. This falls under an important aspect, which is the trust I established with him. This trust relationship made me present in his life from morning till evening. How is that? Through the regular visits I do. For example, I tell him, you need to reduce the number of cigarettes you smoke per day, to reduce it, not to cut it off suddenly. With each cigarette he smokes, he will remember me till he quits smoking after a certain period of time. Or if I told him to stay away from bread or junk food because it will affect his blood pressure and sugar level, accordingly I will accompany the patient throughout the trust I built with him in the present time and for the future. Regarding the second point, which is accompanying my colleagues, me and Bram mentioned that we work in teams of 2 or 3. If one of us was absent, or if we faced a difficult situation, as I mentioned earlier, if we go to a house where the occupation has arrested their son, or if they have a martyr, and sometimes we face a lot of challenges till we reach the house of the patient. Sometimes the occupation shoots at us or throw gas bombs on us. I may not feel okay and won't be able to do my work. My colleague would cover for me, or I may do part of the work and my colleague do the other part. That's why it is very important to have colleagues with you, as it is one of the reasons to success in our work, and to be with the patient mentally before accompanying them physically.
Thank you. Shukran kathir. I think this really is it's interesting to highlight accompaniment in this moment, because I think it's also just about love, right? Like, if you can help people with their health and their well-being, particularly under this kind of environment. And as Sara is saying, people are saying, well, she spoke to me about what to eat. She spoke to me about exercise. She spoke to me about smoking. She cares for me. And that caring piece is really important when it comes to healing and justice and all of that. And so I thank you for highlighting that component that you are playing in so many people's lives. So just a great honor to hear this aspect of your story. So I know you all are learning a great deal, I hope, and enjoying the perspectives that you're hearing thus far. I encourage you to send your questions along as we move into this third and final section where I'm moderating, and then we'll move into the Q&A. So for those of you who are listening in or looking in, thank you so much today for your participation and your engagement, and keep the questions coming. I want to move into this final section where we're really focusing on challenges and solutions and the intersections with social justice. The work you both described is important. It's inspiring. It highlights what's necessary in this particular political moment. However, we know that challenges arise in all of these efforts. And I'd like to start with Sara and then with Bram, and ask each of you to highlight one challenge, how you're overcoming it, and if you feel inclined, how you think our viewers can support you. So first to Sana and then to Bram.
تمام. فكرة الكوميونتي هيلث وركر أجت.
The idea of the community health worker came as a reason of us facing many challenges. Some of these challenges we cannot overcome, or there is no current solution for it, or the solution would come only on the long run. The main challenge that faces us and all Palestinians, whether they have chronic diseases or not, is occupation. Occupation is the main obstacle for us for not being able to treat the patients or support them, or reach to a solution where we can treat their chronic diseases, whether it is cancer or stress or heart diseases or strokes or heart attacks. Occupation is the biggest challenge and obstacle we face. We challenge it, and God willing, all these diseases will be treated. Another point is whenever we go on a home visit for a patient, we have a strong trust relationship with them. The patient would tell us, I need this medicine which costs this and this, or the doctor told me I have to undergo a surgery, and I have to tell him that I may not be able to help him. This is one of the main challenges that faces us, not being able to provide financial aid for patients or connect them with a hospital or a doctor to provide them with the treatment needed. It is a very difficult challenge. For the past year and the time being, COVID crisis itself is a large challenge for us. Why? Because we as people who live in camps are marginalized. UNRWA was not providing healthcare needed for us, and no one else is doing so. We don't have quarantine rooms, nor we have vaccines or anything. The entitled authorities did not provide these services, especially in the time of COVID. Accordingly, we went to the field and provided as much as possible of support and aid, such as sanitizers, awareness among people, tried to mitigate the effect of the crisis on the people. Until now, we are trying to contact health organizations from the national authority and the government, to that UNRWA, so that they can provide vaccines for people in camps. But no one is responding. Stepping in to do a role that is not our role is a big challenge for us. People trust us to provide them with the support needed, and we are their safe place. This is one of the challenges that we faced during the recent period. Another challenge is there was a patient who has high blood pressure, for example, from the work he does, or having a hard work job, or because of he smokes. The surrounding circumstances are very hard on all levels, whether it is economic, social, psychological, and all other aspects. Sometimes we have to convince the patient with a solution that is very difficult to be implemented. And that's why we need to collaborate together to reach to a solution that is suitable.
Thank you so much, Sada, for highlighting both challenges and how you're all responding, and the things that you feel like may need a greater response than what you are able to do as a CHW. Over to you, Bram.
Yeah, I mean, I think the biggest challenge we face conceptually is just the health system in the occupied Palestinian territory is completely fragmented and fractured. This is a temporary occupation that's been going on for 54 years. And so what you have is a split between UNRWA, the UN system, which is underfunded, particularly because of United States budget cuts. You have a Ministry of Health as part of the Palestinian Authority, but the Palestinian Authority only has jurisdiction in 38% of the West Bank, and is also underfunded. And then you have, a burgeoning private and NGO network. And so you have no continuity. You don't have a strong public health system to build into, right? And so people like Sada and our community health workers try to act as glue between all these fractured health systems to get, their patients, who as refugees living in camps are some of the most marginalized and vulnerable, to get them the services they need. But we don't, there is, without a geopolitical solution, we don't have a system to start building into in a more comprehensive long-term way, right? So the ultimate challenge is, how can we take the example, the extreme, courage and strength of people like Sara, talk about it, share about it, expose the situation so that there's pressure from third states like the United States and others that support unconditionally the Israeli, what is now known as the Israeli apartheid state, according to Israeli human rights organizations and Human Rights Watch, to pressure them to change the situation, to change the status quo, because it's just untenable. And I think, as amazing as all the health work is that Sara and others are doing, this is a political problem driving this, and it's going to require a political solution. And so I think, the challenge is, can we pressure our politicians? Can we change the narrative and the situation at that level?
Thank you very much, Bram, for expounding on this. And thank you, Sara, for your contribution to this question around challenge as well. And really the interconnected challenges between health and politics. So for everyone who's listening in, thank you so much for the questions. Please keep the questions coming in. I'm just looking at them on my phone, so I'm not ignoring you. But thank you for that. And our final question from us before opening up for the Q&A for both of you, starting with Sara again, is that we understand here that community health is about health, but it's also about social justice and equity and righting historical wrongs that have likely created, as you've described, a lot of the poor health outcomes that exist. And so we're curious how you each think about the intersection between social justice and community health. And then if you can expand on, where does your work go from here in this moment? And we'll start with Sara.
Regarding social justice, I don't know what to say. Till this moment, we have 230 marchers, and no one from the international organizations, especially health organizations, did anything. Where is the social justice here? Where is the social justice if we are living in a camp and we don't have a 24/7 7 days operating clinic? If there is a pregnant woman who's in labor, or there were clashes with the occupation at night to arrest someone, and there was an injury, the ambulance would be late. Where is the social justice? Whenever we are talking about the intersection of health services and social justice, the result we have here in Palestine is zero. Our hospitals are not suited 100% for receiving patients. If a cancer patient needs to take his treatment dose, he needs the approval from the Israeli side. If a child was beaten by a snake, he can't get the treatment unless Israel approves it. Which social justice we are talking about here? We lack social justice 100%, and all the negative consequences are seen in the health sector. There's a 80 years old patient who has high blood pressure and diabetes. He borrowed money and asked for help to reach the clinic of the UNRWA, only to find out that his medication are not available at the clinic. Where is social justice here? I ask this question to the whole world. Where is the social justice? And we don't have a health system in the first place. We applied the idea of community health workers because we don't have social justice in the health sector especially.
Thank you for your honesty and your directness about the current state of affairs. Bram.
Yeah, I mean, I think I don't have a lot to add to that. I mean, I think that's it. There is no, justice. There's no fundamental sense of justice in terms of the current situation, as it stands now. I think for all the reasons, we stated, it's like, even some basic things not available in the West Bank, right? You have to get a permit. Permits might be denied, even to go to a hospital in East Jerusalem, which is part of the West Bank. East Jerusalem is part of the occupied West Bank, right? It's illegally occupied, and the main Palestinian hospital is there, Al-Maqasid, and people in Sara's community just 6 kilometers away can't get there without a permit, many of which are turned down, especially for young people like Sara.
Thank you. very much. I think that when we started to craft this webinar, we were thinking about these intersections: social justice, health equity, community health, and how do we respond at the most grassroots level to these kinds of injustices and inequities. And I think what you all are modeling in what may be, some of the most challenging environments on the globe is really the best of what we are able to do as communities when it comes to health. But what you're also, I think, demanding of us as an audience is that we do more to push forward the work that you're doing. And so I hope that for those of us who are listening, that we are thinking about all the ways that we can contribute to the dismantling of inequity, both where we live and where other folks and friends and colleagues live and work all across the globe, including in the West Bank, in Gaza, and in other parts of the planet. So I thank you both for your level of directness and authenticity and your passion in this work. I'd like to now open up for the questions that are coming from the audience. Pretty dynamic ones, interesting ones. And so we have about 30 minutes or so of Q&A. So if you haven't had a chance to ask a question, please feel free to keep them coming in. This first question is for Bram. This person says, you mentioned sort of data sharing. How do people get access to their data once it's collected, and how does it get shared or made available in a form that people understand? I'll pause.
Great, yeah, and I mean, this came up because patients were saying, people were saying, I don't know, like UNRWA, they take blood draws, but I never see it. Like, the UN, they have this data. I don't know, we never get to even see it. And so, we started collecting our own data and on the phone with COBO. And so the community health workers, the same people are, spending all this time with patients, really have that at their fingertips. And so they can share it back directly. When they did this summer camp, right, there was a lot of discussion about that. We've recently completed an analysis on our first year and a half on diabetes results, which were fantastic, and are currently writing that up. But we're planning a session to share back that information, to know that as a community, they've done it, very well in terms of controlling diabetes in the first year and a half of the program. So these are some of the ways. But I think the key thing is, the community health workers have all the data at their fingertips. They can share it back at any point, whether it's, their blood pressure, their latest hemoglobin A1C, and things like that.
Great. Thank you for that. There were actually a lot of questions about data sovereignty in here. So I hope that's helpful to everyone who asked about these issues around data sovereignty. There's another question here and some comments. So I actually maybe want to read some of the comments for you all. Someone says, thank you for this wonderful discussion. I'm tuning in from PIH, Sierra Leone. Someone else says, good job, Sarah, many exclamation marks. And thank you, Dr. Brown, for this work. So I just wanted to share a little bit of the positive energy that's coming through in the Q&A. But then there's a question for you, Sarah. And this person says, what is the most challenging part of your work as a community health worker? And I think you shared some of this, but maybe having a chance to expand, but also what is most rewarding about what you do?
ممكن أجاوب على الشق الثاني بالأول.
For sure, you develop in this work, and there's a chance for this idea to develop and grow, as there are community health workers in Al-Azza and the Aida camps. For example, there's an elder person who's 85 years old, and he has no one who takes care of him, and he lives alone. This idea is very beneficiary for him. And it could be implemented in all camps in Palestine and in all refugees camps, because it's a very effective idea. Whenever we provide the health care for someone for 15 or 30 minutes max, this brightens his whole day. He feels that he can go on in this life. The biggest challenge we face is occupation. Our center is located next to a military watchtower for the occupation, and whenever there is a patient who calls for help, the occupation prevents us, And whenever there are clashes, gas bombing and shooting, especially in the time being, it is very difficult to reach these patients, and it is a big risk. We always take these risks in all weather conditions, and if there was an attack by the occupation or there's not, we provide this support and aid because this is a message we believe in
Thank
and
you for
we want
sharing,
to deliver.
the positive aspects of your work, how you feel that you make other people feel as they continue on their journeys of healing and wellness. And so great appreciation for that. A few more questions coming in for you. I think Brahm, here's one. This person says, I want to ask about the program's sustainability and community health worker motivation, considering financial or non-financial incentives. So I'm not sure who wrote this, but I know, in many other contexts, whether it's Rwanda or Ethiopia or India, there are different payment structures and other forms of incentives. And so maybe this person just wants you to expand on that and how it may be similar or different from other contexts.
Yeah, it's a good question. I mean, the payment is currently coming through an NGO. So there's a Boston-based NGO called One for Three that's partnered with the Laji Center, right, the Refugee Community Grassroots Center in United Camp, and that pays the salaries, which are around or a little above kind of minimum wage in Palestine, in an area with very, very high unemployment. From a sustainability standpoint, right, it isn't, these are 2 of 20 refugee camps in the occupied West Bank. There's 8 refugee camps in Gaza, 12 in southern Lebanon, right? So even just talking about expanding this to all Palestinian refugee camp communities in the region, right? And then of course in Syria as well, and many of those have been destroyed. That this is very challenging, and it's not something we can just do through NGO fundraising, right? And so I think, from the sustainability lens, there's different angles. One of which is the possibility of partnering directly with the UN, and sort of what we're trying to do is show how impactful this program is in terms of at a social accompaniment level, right? But also in terms of its outcomes on diabetes and hypertension, because UN serving Palestinian refugees, UNRWA, also has a mandate for jobs creation for Palestinians because they're living under military occupation. It's not a normal economy. They don't have control over their economic future or any other aspects. And so thinking about, ways we can have the UN as an, representative of the international community take responsibility and potentially ultimately take on this programming for Palestinian refugee communities until the international community takes responsibility to achieve justice for Palestinians the world over, refugees and otherwise, which has been lacking for the last 75 years.
Thank you. And thanks for highlighting, I think, a little bit about the collaboration across boundaries. So it sounds like One for Three, as you mentioned, is in the US, Laji is in the occupied territories, the organization you all founded, Health for Palestine. So really thinking about how that kind of solidarity happens across borders and boundaries and barriers and walls and, all the things that we have created as societies to keep folks apart. So thank you for highlighting that, as well as the other aspects of the work. So keep the questions coming, but there's another one here. So we're getting a lot of comments that just say, thank you for your brilliant work. So I want to share that. And so this person says, thank you so much, Sada and Brahm, for a brilliant conversation. In the absence of cohesive and coordinated health systems, what would you advise international aid organizations to do, the folks who are supporting the health sector? What would you like to see be done differently? And maybe I'll start with Brahm and then hand over to Sada on that question.
Yeah, I mean, a big problem particularly since the Oslo Accords were signed 30 years ago, is that international donor community has largely driven the agenda through money. So through neocolonialism, they have depoliticized Palestinian resistance in favor of programming that is apolitical and doesn't challenge the root causes of Palestinian suffering. And so what's important, I think, is that we flip that paradigm back and we say, hey, these are the structural, these are the political determinants felt. We need to support initiatives that allow Palestinians to actively resist through whatever means, including resistance through health organizing, the occupation, the settler colonial reality, and the apartheid reality that is their lives. And so my feeling is that it's very important that we stop the donor-driven agenda that depoliticizes Palestinian resistance, because they have a right. They have a right under international law to resist by whatever means necessary this illegal occupation. That is their right. And so I think it's important to think about that as sort of I'd say the basic starting point of then how we might think about what initiatives we're going to aid and who we're going to aid.
Excellent, thank you, Bram. Sada, would you like to add anything in response to this question about what you want international organizations or international aid organizations to do differently based upon this fragmented health system that you both described?
ممكن إحنا
As I mentioned before, we don't have 24 hours operating clinic, while anywhere in the world you'll find clinics who operate 24/7 to respond to any emergency situation. For example, if the occupation attacked the civilians in the camp, this clinic will be ready to support. The biggest challenge we face is occupation. Only if international health organizations would stop the occupation from attacking the camp, which is something impossible. The occupation hurt people, they arrest the youth and kill them without any reason. We can provide a sustainable health center that provides support and aid to people 24/7 and not only from 8 a.m. till 4 p.m.
Thank you, thank you. Thank you both for responding to this question about sort of the international aid structure and the dynamics of that, and how that sort of gets into the weeds of the work that you'd like to see. There was I think also a question around, I think for folks who are maybe new to sort of the UN language and how the UN engages with Palestinian refugees. You all mentioned UNRWA a couple of times. I'm wondering, Bram, if you can just expand on who UNRWA is, what do they do, what are they responsible for? And as you said, maybe how you all may or may not connect with them in the present or the future.
So UNRWA is the United Nations Relief and Works Agency for Palestinian Refugees in the Near East. That's the full title. So UNRWA, it was a specific body by the UN created because the international community created the Palestinian refugee crisis by promising to split the land in the Balfour Declaration 100 years ago. So the international community is directly responsible for backing the Zionist political movement to establish a Jewish state in historic Palestine. And therefore, because of that responsibility, they felt the need to set up, separate from UNHCR, a UN refugee body that's specific for Palestinian refugees. But it does not have a political mandate. It only has a mandate around things like health and education and jobs. So it can't advocate politically at the international level. But what that means is that for Palestinian refugees like Sada, it has health services, primarily primary care, and then it helps pay part of and not enough of any care that happens in an inpatient hospital setting. But it also provides education, provides schools. Right at this moment, we just received notice, for example, that two UN schools in the Gaza Strip, that's housing right now women and children and people who have fled their homes because of the bombing. They've come to those schools. Israel stated that it's going to blow up these schools with people inside them because they say that's housing Hamas assets. So this is literally, we just got this notice a couple hours ago. And so, there are direct attacks on UN, on UNRWA from Israel. Certainly at a political level, they're constantly trying to delegitimize the UNRWA services that Palestinians get. The Trump administration in 2017 cut 30% of UNRWA's budget, all of the United States portion of the budget, which was 30% of their budget, so for health and education for Palestinian refugees, was cut to zero. Biden just put back 150 million, so only less than half of what was under the Obama administration. So there was a lot of applause in the liberal press, but in fact, much, much less support for Palestinian refugees than prior US administrations. And so this is the context. This is what UNRWA is. It's in many ways, the refugees, and Sarah can talk about this more, the health services are insufficient and they're not well trusted, but UNRWA is also maintaining the status of them as refugees from generation to generation, which is the correct case, right? Which is just. And so it's important to maintain UNRWA until, again, there's a solution, until Palestinian refugees can return to their home villages inside of what is now Israel.
Thank you for that sort of accurate historical lesson. And I think that might be complicated or complex for folks around UNRWA versus UNHCR. And so UNHCR being responsible for all other refugee communities all across the globe, right? Whether it's the Rohingya or folks coming out of Syria or Sudan or Eritrea, and then UNRWA being responsible only for Palestinian refugees who have been displaced for decades. And I think that distinction is really important to understand that there is a UN agency responsible for Palestinian refugees because of the historical displacement and disenfranchisement. So thank you for, history meets health in this webinar, but thank you so much. So we have just about maybe 10 minutes left, and we have some more questions in here before we wrap up. There's a lot more of just thank yous and shukrans and appreciation for you and your energy and your willingness to talk at this time. This question I think maybe can go to Sara, and then Bram, feel free to jump in if there's more. But essentially the question I think now is, you're highlighting kind of the UN relationship to the Palestinian refugee experience and to your own work. How does the Ministry of Health in Palestine engage with you or not? What is that intersection between your work and the Ministry of Health's work?
تمام. إحنا من عام 1948.
We've been refugees since 1948. UNRWA was established in 1950. According to the international law, it is responsible for providing the Palestinian refugees with the health and education services. Education services are still provided only for schools and not at the university level, but for health services they should provide it. I'll give you a live example. Providing COVID-19 vaccine. Can you imagine that the UNRWA did not provide any vaccine for refugees living in camps? There's a huge degradation in services provided by UNRWA, and at the same time the Ministry of Health says that this is the role of the UNRWA and they can't overlap with it. The victim is always the Palestinian refugee. How the Ministry of Health and the government provide the support. They are responsible for non-refugees and the people who do not live in camps. Whenever the situation is about politics and health, politics wins and health always loses. The national authority says refugees fall under the responsibility of UNRWA, and the UNRWA says some services are under the responsibility of the national authority, and we are lost between them. We reached for the Ministry of Health and for UNRWA to provide COVID-19 vaccine, and as it is a health right, we organized demonstrations hoping that the message is delivered. And at the end of the day, it's all about politics. This was plotted by the occupation long ago, since 20 years or so, and we are seeing the results now. Refugees fall under the responsibility of UNRWA, but if UNRWA delegates its responsibilities to the national authority, our cause will die, and for sure we don't want for that to happen. UNRWA should provide the services for us.
Yeah, I mean, that's exactly it. It's complicated because we've spoken directly with the Minister of Health, the Deputy Minister of Health, and thinking about ways we can work together with them. But because in fact, what the United States and what Israel want is for health services to be taken over by the Ministry of Health, by the Palestinian Authority, and by other, and away from UNRWA. Because if they can destabilize UNRWA and make UNRWA fall away, then that helps them fix their problem with Palestinian refugees. So it's a little bit complicated to understand. So in fact, while the Ministry of Health would like to at times be more involved, in fact can't, because if it takes over the services that the UN is providing, the refugee services which are due to the people as refugees, then it will destabilize their ongoing claim, their just claim for refugee status and the right to return, as all refugees have in the world, the right to return to their home villages.
Wow. I mean, the complexity of the intersection, right, of like identity and politics and these sorts of decisions sound like, and I think I wrote down, Sada, as you were talking, that people get lost in the middle. And so if this level of fragmentation is allowing for people to drop through the cracks, then your role as a community health worker is even more important, right? At the connections that you're making for folks to services, as well as to, these other more complex political dynamics. So just grateful for hearing about what's missing, but also how it sounds as though you all in Health for Palestine are filling what is a confusing and difficult gap. Interesting. So someone says, what books, films, or other resources do you recommend people turn to learn more? While you both think about that, I'll just share with everyone who's in the audience that as always, when we finish these webinars, you'll receive the recording. You'll receive a couple of different resources or links to resources. So this question can be answered here verbally, but maybe also through the email chain that will come to you. You'll also get other kinds of information and materials, a link to Health for Palestine's website and their donation page. So we hope to keep you engaged in this conversation beyond today. But books, films, or other resources that you may like to share at this time. And is that a baby in the window?
ممكن احنا بنعمل في حملة خصوصا على الوضع الحالي على الهاشتاجات.
There are campaigns on social media through hashtags on Facebook, Twitter, and Instagram. You can find all about what's happening there. Also, there are some trusted TV channels that deliver the message in a just way without being unfair to the Palestinian cause. I can send you the links after the meeting to be accurate. Also, I would like to point out something related to challenges. The biggest challenge we face could be that the government and UNRWA and the whole world are trying to run away from the health responsibility of the refugees.
Yeah, I mean, I think in terms of books in English, a recent one that came out by Professor Rashid Khalidi from Columbia University called The 100 Years War in Palestine is really good because it really also centers, for those of us who are Americans, the US role in dispossessing Palestinians over the last century. That's a really good one. The Battle for Justice in Palestine by Ali Abuma. Israeli historian now in exile, Ilan Pappé, has a book called The Ethnic Cleansing of Palestine. That's really excellent. Some of his other books as well. So those are some I would just say as starting points too in English.
There's a book, I don't know if it is translated into English. It is titled Palestine and the Palestinians for Samih Farsoon. It talks about the Palestinian cause in a just way.
Thank you, Sada. Thank you, Bram. Just really excellent responses to these questions. I think we're just going to take one more here before we start to wrap up. So thank you all so much who have tuned in for the questions and the comments and the grace that you have given us all with your time this evening. So this person says, thank you for the hard work you're doing in areas where social justice is hard to achieve. My question is, what are the strategies that you are using or could use for the health system redesign? And, in some future world where you're able to redesign the system, what are the strategies you are or would like to be using? And I'll give you a moment for that. And we can start with Brown, and then Sara, feel free as well.
Yeah, I mean, I think there's an opportunity because of the fractured, fragmented nature we talked about for a community-driven approach, right? And a community-centered approach, because that's the only option we have, in some ways right now. The rest is, again, at a political level that, we can do advocacy for, and we need to. But, I think many health systems, including certainly in the United States, can be strengthened by community-based, community-centered, and all, community-run, right? You have people like Sara who are just in the trenches doing this work and are deeply connected to the population they're serving. And I think this is a form of health work that I think thrives in even, conditions in, wealthy but very inequitable countries like the United States. And so I think, this, at least to me, regardless of what happens or doesn't happen politically, is the seeds of what I personally feel like a health system should be, which is, the community taking as much control as possible in its own hands to take care of itself and control its destiny. And so I think empowering people to do that, I think that hopefully this can be a model even beyond, this occupied Palestinian context.
Excellent, excellent. Thank you so much for that. I mean, I think you've brought us to our closing quite directly, and tied into why we have this webinar series. The webinar is entitled Committed to Communities. And the reason we have centered that for 2021 is just the reason you described, is that in any kind of system redesign, in a setting that may be considered safe, and in a setting that may be considered conflict affected and occupied, and all of these different environments where we're all working, that centering communities may be one of the most important things we can do as we move forward in our own healing and the healing of communities and neighborhoods that we work with. So thank you so much for highlighting that. I guess what I might ask Sara, if there's anything you'd like to add to what Bram shared, or any closing statement that you'd like to share with our audience this evening before we wrap up.
Thank you for your attention and your participation. I hope we can have more of these meetings so that we can convey to the world the situation in Palestine, the war, the crimes, the arrests, and what's happening. As a community health worker, I hope to share our cause with the whole world, and I hope that you can visit us in Aida camp in Palestine and see what's happening on the ground and share it with the whole world. Thank you so much.
Shukran, Sara. Thank you so much for those closing words. And I hope that you all join me in thanking Sara and Bram for their time and their energy and their commitment to sharing with us today in what is a very challenging moment in Palestine. I think in closing, what I would just like to share is that we come together in this way in these webinars because we're committed to communities, because we see communities as part of the solution in health, in other aspects of wellness, as well as in the political dynamics in places like Palestine and Israel. Community control, as Bram mentioned, is so central to what we think in our research and our teaching and our practice, and I hope we can continue to highlight that. I also want to highlight the health of refugees in general being a centerpiece for what we do in the work of global health or global public health, and that when we think about marginalized communities or communities actively pushed to the margins of societies, that we are incorporating refugees and other forcibly displaced persons in the work that we do over time. And lastly, that we are in solidarity with all marginalized persons across the globe as we think about how to make ourselves well, how to heal on individual levels, on social levels, on community levels, on national levels. And so I thank you all so much for your time, your energy, your passion, your commitment. And I hope to see you next time. Murakozi chane, shukran katir. Thank you so much. Have a good night.